And thank you so much, Deanna, Heather, and everybody for making this possible for me. I really appreciate it. I appreciate the opportunity of being able to do it also remotely. I want this to be as useful and hopefully interactive. So I'm going to leave plenty of time for us to have a discussion so that you can ask me a number of issues that arise around the so-called atypical or so-called ectopic acromegaly. The first thing that I'm going to start off is by saying that when we talk about acromegaly, it is not just thinking about somebody who's coming in with big hands and feet. Yes, it is. But the point from this slide is that everything we're going to talk about when it comes to diagnosis is going to be predicated by knowing that there is some clinical suspicion, meaning that there's something wrong. The patient recognizes or their family recognizes that there's something wrong. And it's not just a matter of what's on the outside, but I want to really emphasize that this is a lot more than just big hands and feet. It's about all of the things shown on this slide. Everything where hopefully the penny will drop when not all of these things are there, but when one or two of them are there without good explanation. Somebody who has heart disease, I don't want to get a referral of somebody diagnosed with acromegaly because they're at end-stage heart disease and someone has missed the ball for decades. That's no good. The point that I want to emphasize here is that when we talk about acromegaly, regardless of the type of acromegaly, it is predicated on having to look for it in the right clinical setting. And the right clinical setting is not just about big hands and feet. It's about somebody who has more than one problem that cannot be easily explained. And these can include, in no particular order, heart disease, breathing problems, obstructive sleep apnea, high blood pressure, diabetes, someone who's not feeling well. The last patient that I got referred with acromegaly actually had lymphoma. He was being treated with lymphoma and for the lymphoma, and it was the persistent sweating that made the referral to us, and we made the diagnosis of acromegaly. He probably had it for about 10 years. So I really want to emphasize all of this is predicated on a clinical suspicion, a suspicion that something is not quite right. I mentioned this the other day, but it's worth emphasizing. The reason for that is that regardless of cause, and we're going to talk about the gory details in a moment, but regardless of where the growth hormone is coming from, it affects every part of the body. Every single cell in our bodies has growth hormone receptor. It is sensitive to growth hormone and especially to growth hormone excess. That includes your liver, fat, muscle, bone, skin, hair, heart, kidneys, bowel. All of them will see the effects of too much growth hormone. The other thing to remember is it's not just growth hormone, but its cousin, IGF-1. The difference being that growth hormone tends to go up and down, IGF-1 tends to rise and is relatively more stable. They each provide a slightly different side of the picture. By and large, we would expect, but not always, that both growth hormone and IGF-1 will be elevated. Now, I'm going to go from the simple, and I'm going to take it to the more complicated, because I have to tell you about the typical so we can get to the atypical part. The typical part is shown on this slide. This is the textbook description. This is what every physician wants to see. So let's start with that part. And that here, the gospel tells us there's going to be a tumor. It's going to be sitting right in the pituitary. Nobody's going to miss it. That tumor is releasing growth hormone, and it's spitting it out inappropriately to the point where it's overwhelming the liver to produce IGF-1. Both growth hormone and his evil cousin IGF-1 both work on overwhelming every part of the body. And that's why we see what I showed you earlier on the slide: diabetes, high blood pressure, heart disease, obstructive sleep apnea, and so forth. Now, what we would normally expect is that the growth hormone and IGF-1 feed back at the level of the pituitary to shut this off. But that doesn't happen in people who have a tumor. Why? Because the tumor doesn't listen. It doesn't recognize that this sink has filled and is about to overflow. Now, I want to take you to the next level. There isn't just one growth hormone. In fact, there's a physiologic state that a lot of people know about where there's too much growth hormone, and it's not puberty, it's actually pregnancy. In pregnancy, there's a very, very high amount of growth hormone, only it's not coming from the pituitary. It's another form of ectopic growth hormone secretion, which actually comes from the placenta. And that's why a pregnant woman will have elevated growth hormone and IGF-1. And if you think about it, state of pregnancy is associated with fluid retention, weight gain, a predisposition to high blood pressure and diabetes. The only difference is when the placenta is removed, many of these issues tend to resolve. Now, there are some instances, however, where what we have is a patient who is pregnant and has acromegaly. I'm bringing this point up here for one reason, and it's very important to emphasize this. Up until recently, a lot of patients who had active acromegaly, whether they knew it or not, and depending on how normal or safe the growth hormone and IGF-1 levels were, they may have had issues with infertility. And that applies to both men and women, by the way. Except in the case of women, obviously, these women, if very well treated, will hopefully get to a point where they're normal enough to be able to ovulate and actually have a pregnancy, and a normal pregnancy for that matter. And it's important to emphasize that it is possible not only to be pregnant with acromegaly, but that you can be managed and, if necessary, treated during pregnancy. And that is a situation where, again, the growth hormone is coming from two sources in a situation, from their pituitary tumor as well as the placenta. So it adds to it. So that's a situation where there is an excess of growth hormone coming from above and from below the pituitary and the placenta. Now, the situation gets to be a little bit more dicey when someone is found to have clinical reasons to measure growth hormone IGF-1. The growth hormone IGF-1 are measured and they're elevated, or one of them is elevated, but there's no tumor. No tumor in the normal area where we would normally expect it, in the pituitary gland. And that's shown on this panel here. This is the most typical, where the pituitary is the source of a growth hormone, the tumor is there, and that's 95% of cases. But in some instances, when you can't see it on the MRI, it doesn't mean that it's not there. It could very well be outside of a pituitary, and that we call extra-pituitary, meaning the growth hormone producing tumor is outside of a pituitary, and it can be in many areas, which I will talk about in a second. But the point is, those individuals will have a perfectly normal MRI. In fact, they may even have pituitary surgery, and no tumor is found in the pituitary gland. So that's extra pituitary growth hormone excess. Now I'm going to take you to the right panel, where there is an excess of a hormone coming, again, outside of the pituitary, but it's called growth hormone releasing hormone, or GHRH. And I hope that some of you are familiar with that term where it applies, because that is a hormone that actually tells the pituitary to do the wrong thing. It actually stimulates it to produce an excess of growth hormone. So the pituitary is not at fault. It's getting the wrong signal. It's getting a signal from another tumor outside of a pituitary, and that is what's called ectopic GHRH. So though there's two major forms of so-called ectopic acromegaly, which is what Deanna asked me to talk about. The one on the left is extremely rare. The one on the right is rare, but not extremely. It is one where typically it's a tumor in the lung or in the pancreas, and I'll speak more about that in a moment, but I just want you to be aware, the net effect of that situation is that the pituitary is sending out growth hormone in excess, but there's no tumor in the pituitary, it's just getting the wrong signal. The end result in all of these conditions is an excess of growth hormone and IGF-1. But obviously, surgery on the pituitary in these two middle and right panels will not be effective. Now, where can we find these tumors? And that gives rise to the term neuroendocrine tumor, which you will hear me talking about again and again. And the term comes from when we go through development as a fetus, we're made up of very different layers. We start off as being a tiny little number of cells. That's the embryo. It turns into a fetus, which is made up of a tiny little tube. And lo and behold, the front portion, the so-called foregut, gives rise to endocrine cells, hormone-producing cells, which include the pituitary, the pancreas, and the lung, and others. And you'll hear the term foregut. I just want you to remember that term, which just simply means that the pituitary and other endocrine cells arise and develop from the front portion of the fetus. Now, the actual details are shown on this slide, which can be a little bit overwhelming, but I wanted to emphasize something. The broad family, when you talk about tumors and somebody asks you, where does acromegaly or pituitary tumors fall? What family do they belong to? They belong to a family of so-called neuroendocrine tumors. And that's why very recently, the World Health Organization accepted the proposal that pituitary tumors be assigned and given a code that makes them belong to the family of neuroendocrine tumors and is now designated PITNET, or pituitary neuroendocrine tumor. Now, this slide introduces you to the rest of that family. And you can see it's an extended family, the pituitary being one, but next to it is also thyroid, lung, pancreas, and even endocrine cells in other parts of the body, including the rectum. And you will also hear about tumors that some of you may have heard of that are called paragangliomas and pheochromocytomas. These are cousins of that family that belongs to neuroendocrine tumors, the pituitary being one member of that family. It's not unusual for this family to have a little bit of, shall we say, intermingling, in that sometimes they will make hormones that are very familiar to the other cousin. And one of them that I referred to earlier, where that neuroendocrine tumor will make not only what it typically produces, but will also make GHRH, hence the ability to stimulate also the pituitary. Now, there are some practical implications. What I'm telling you about doesn't just simply belong to science alone. It actually has some clinical implications, which I will come to in a moment, that will explain a little bit about what it means to the public and patients at large. But I really want to emphasize this point here, is that the pituitary is a member of a broad family, and that is now accepted as the neuroendocrine tumor with the pituitary, and that includes growth hormone, obviously, the PITNET designation. Now, I want to show you this slide for one reason and one reason only. This is an MRI where the nose is sticking out of a screen, the ears are to the sides. And you can see that the arrow is pointing towards the main component of a tumor. The black holes on the right and left are the carotid vessels. They pass through a structure which I want you to become very familiar with, and hopefully you've heard it before, but you need to remember it again and again, and that is the cavernous sinuses. Cavernous sinuses. Why is that important? Because you can see here that this tumor is extending and invading through, and you can see here it's coming to the other side of the cavernous sinus. It's making its way through between the blood vessels, and actually on the patient's left side is invading into the brain. This is the reason why many patients, and some of you in the room may even appreciate this, because you have surgery, you remove the central portion of the pituitary, you remove a lot of a tumor, but there's also a lot of tumor that's left behind. You cannot enter into the cavernous sinus safely. Indeed, you cannot and should not, because there are a lot of vital structures, including the carotids, and this can be catastrophic if you nick the carotids, because that patient will end up with major disaster. There are also nerves here that supply the peripheral vision and the movement of the eyeballs. The other reason why I'm showing you this slide is that many patients end up having nothing but a tiny little rim of tissue left in that cavernous sinus wall. And it's very hard sometimes to identify this on the MRI. And that will make people think, oh, maybe the tumor is outside of the pituitary. This is the reason why I'm belaboring this point. I should add, the normal residence of growth hormone producing cells in the pituitary is in fact in the lateral wings, in the sides of the gland. It's not in the middle, it's in the sides, which is the reason why a lot of pituitary tumors that produce growth hormone, when they grow, they start to grow not only in the middle of the cella, the box where the pituitary sits, but also have a high likelihood of invading into the cavernous sinuses. So again, I want to emphasize the MRI localization of disease is very, very critical, and it's very critical in identifying where residual disease is present, especially when a patient's had multiple operations, maybe even radiation, and still has active disease. And people are asking, where is it? Where's it coming from? Or in some instances, the tumor is in fact a tiny little rim of tissue sitting in that lateral cavernous sinus wall. I cannot overemphasize this. And that's why the goals of treatment of any form of acromegaly, pituitary or ectopic, normal or atypical, is to find the source. And finding the source may not be so easy. You may think that it's going to hit everybody in the face and they're going to find it very easily. Not always the case in the initial diagnosis or in recurrent cases. We obviously want to find the source because that's the best opportunity for us to be able to eliminate the disease. We want to normalize the hormone levels. We want to reduce the tumor burden. We want to do all of these good things that are obvious, but you can't do it if you can't find it. And that's very, very critical. It also means that what you do and how you do it are going to be very much dependent on what you find. Because if you can't see it on the MR, or if you can't see it with certainty, because somebody may have had an operation and now it's a question of whether what's present is scar tissue or tumor, or maybe the tumor is not even in the pituitary, then you need to have not only a very good neurosurgeon, but my second point here, and that is that the preoperative imaging is equally as critical. I cannot overemphasize that point. The access, the experience, the technology, all these things are not going to work if you don't know what you're dealing with. And I emphasized this the other day, and I'm going to emphasize it again. Regardless of cause and where the tumor is, you may not necessarily want to go in and operate on a patient. You may, in fact, want to consider the possibility of medical therapy. Get the patient under control medically. Get the hormone levels under control. Get them feeling better. And we know that we can do so because we've got medications. We've got medications of every category you can think of: dopamine agonists, somatostatin analogs, growth hormone antagonists. I'm not going to go through the details, but the point is that we've got lots of drugs that we can choose that can bring the situation under control while we're looking for the disease. And one additional way of looking for the disease is going to be my next few slides here. What do you do when you can't find the tumor on the MRI? And that gets us into an area that you need to be aware of, which is present in that family of neuroendocrine tumors. And people in the neuroendocrine world know about this, but in the pituitary world, it's not as well appreciated. And that is PET imaging. What is PET imaging? PET imaging is basically where you take a substance, in this case, a drug. You can take the drug that is given to many patients with acromegaly, except you attach to it something red, yellow, or green here, which is basically a radiation material. You inject it into the patient, and then you watch where it goes because you've got a camera that's able to detect the radiation. And you can get an image that looks like this. This is an example of somebody whose tumor is not in the pituitary. In fact, the tumor is sitting down here in the pancreas, and it has spread to the liver. It's a neuroendocrine tumor. And we know it's a neuroendocrine tumor because it is able to be captured by this PET scan that is made up and recognizes where somatostatin receptors are. These are the receptors that mediate the action of the medication. In this case, though, we're not treating the patient. We're using the drug as a chaperone, as a lead to show us where the disease is. And PET imaging is one way of identifying this. You may have heard about it in other contexts where somebody, for example, with lung cancer, and the patient has disease and they want to know how far it's spread, you get a PET scan, but it's a different type of scan that usually utilizes glucose. Here in the neuroendocrine world, you use what's called a dotatate PET. And I got to tell you, that it was a formidable task to bring this type of technology and this resource into Canada and to Ontario and many other provinces. And it's only in the last couple of years that we've been able to do this and have it now widely funded specifically for the diagnosis and detection of tumors, including neuroendocrine tumors, and specifically in this case, the detection of neuroendocrine tumors that produce a lot of hormones, including those that are responsible for ectopic acromegaly. Now, I want to emphasize this access and this technology and these resources only become available when a patient has a disease that's recognized to belong to a family of tumors. And having the designation of the pituitary as a member of that family of neuroendocrine tumors, or PITNET, gives those patients access to resources that are normally reserved for those who have neuroendocrine tumors. That, I think, is an opportunity. I think it should be taken advantage of in a responsible manner, because it also gives patients the opportunity of other resources, including genetic testing and medications that are normally not made available to people who do not have neuroendocrine disease. I want to emphasize that all of this has been captured in many different ways, and in Canada, there's a group of us that managed to come together as a number of physicians who work as a network, and they've been able to come up with recommendations on how to classify different types of pituitary tumors, whether they're in a pituitary or outside of a pituitary. But the important thing is also to be able to streamline their therapy and recognize that different drugs have different actions and they can be utilized differently to meet and achieve these objectives. We need to take advantage of this. I think that Canada has a lot to offer. The important thing, though, is to make sure that we are doing it in a responsible fashion. And I think that the designation that I mentioned earlier about neuroendocrine disease is very well sort of exemplified by ectopic acromegaly, because ectopic acromegaly is by definition a neuroendocrine disease. It's where the neuroendocrine tumor responsible is present outside of the pituitary, is a neuroendocrine tumor, and typically is in the chest, meaning the lungs, or in the abdomen, meaning the pancreas, and its detection and its treatment relies on resources within that broader family of neuroendocrine diseases. So I'm going to stop at this point, Deanna, because I want an opportunity to be able to have a broader discussion and have people sort of ask me what their experiences have been, and hopefully I've been able to provide a little bit of useful information here. Thank you so much for your attention.
Thank you, Dr. Ezzat. Okay, I'm going to just get people to put their hands up, and I'll bring the mic to you so that Dr. Ezzat can hear your question. Anybody? Okay, you got a question?
Okay, my concern is that I'm one of those that cannot be, the tumor cannot be identified by an MRI. I have been for 10 years now, taking all the medications, and things are under control. But it has never been investigated if I do have the tumor somewhere else. Now, I'm not sure if Ottawa has the capabilities to do a PET scan or not. I can figure that out and ask that question, I suppose. But if I don't know if I should be pursuing it at this point, and if they find it somewhere else, does it mean that I have to have removal of that if it was in the lung or something like that, and then it would eliminate me taking all of these drugs for years? Like, what are my options?
That's an excellent question. Thank you for sharing that with us. And the answer is actually relatively straightforward here. I would definitely, if the tumor cannot be visualized on the conventional imaging, which is CT or MR, as you pointed out, then you definitely want to get a dotatate PET. It is about to become more widely available throughout the province. But if you cannot get access to it right now, your physician can ask for it, and it will be done in Toronto, and it will be done at Princess Margaret. There are also some other sites. The reason why I would pursue it is multiple. And as you pointed out, first of all, you want to get a diagnosis because you want to know exactly how much disease you have, where is it resectable, does it have a potential of spreading, has it even spread, and could it be resected to a point where the need for medication is reduced or possibly eliminated. I should point out, and I don't want to sound in any way negative or pessimistic, you can never really make any decisions until you have all of the information available to you. So even if you feel that you're not necessarily going to act on it, I would still want to get that information so that you can be in a position of being fully informed, and then you can make a better decision about how you're going to act on it. You may even choose not to act on it now, but at least you'll have it in the back of your mind and in physicians' minds. I would definitely go for it.
So I have a question. I've helped a couple people get diagnosed with pseudo or epitopic acromegaly, and it was a really hard struggle. So when somebody is going into the hospital multiple times into the ER and they're saying like, look, my hands are growing, I got migraines, blah, 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 but they can't find anything on the MRI, or can you get an MRI done, but they can't find it. They keep going back to the hospitals. How do we get doctors that work in the emerge to think about even going, hey, you know what, let's maybe think about doing this PET scan?
Did I mute it?
Yeah.
I muted him?
You muted him. Hang on, you got muted.
Can you hear me now?
Yep. Okay.
Okay. All right. So let's be honest here, Deanna. I would hope that the emergency room physician, while they may not necessarily be able to get things resolved or request a PET scan, at least they will get the ball rolling, because the emergency room physician will be able to say, hey, wait a second, this person keeps coming back. There's a problem here. This is not somebody who's trying to exploit the system or making up things. This is a bona fide situation. We've seen this person repeatedly. Let's get this done properly. And at the very least, what you would want is to have that emergency room physician flag it so that this person is seen even in a general internal medicine clinic or an endocrinology clinic. I don't care which one, but at least have this person flagged so that they are seen in an outpatient setting where someone is able to sit down. The emergency room physician, as you know, is not going to sit down and take a history and spend half an hour with that person, but at least they will have flagged that person. And hopefully when they're seen in clinic, these very simple things I'm talking about, and this is not rocket science, to be honest with you. I mean, this is sort of bread and butter stuff. It should happen, and it should happen without the patient having to get the runaround and be begging for it. But hopefully, as I said, those repeated encounters should be a red flag that this patient deserves more attention, and somebody needs to listen to them in the right setting and do the right thing, which hopefully gets them closer to an answer.
Thank you. Another question? Oh, Jill. Oh, here comes Jill.
Question. Whenever they do the PET CT scan, do they look at any other places other than the gut? Because I've had breast tissue that has been removed and my IGF-1 cut in half by that removal.
Again, another very good question. And that's one of the benefits of a PET scan is they go over the entire body from head to toe. So if that tumor happens to be sitting in the ovary, in the bladder, in the leg, wherever it may be, or wherever it may have even spread for that matter, you can find it. And that will allow the physicians to be able to do more dedicated, focused MRIs on that region that lights up on the PET scan.
Okay. I had all these tests, like, I don't know whether it was a PET scan, but my tumor was really small, and I had 2 MRIs before they could even, see, they didn't see anything. So my endocrinologist sent me for the radioactive thing, for the whole body thing. It was an all-day thing because they put the radiation in, and then they, you have to go away for a bit. They come back after they've taken, it's a long day. But I was just wondering if having a small tumor makes it more difficult to find it, and maybe it gets pushed into this ectopic issue before they can see it on your pituitary gland. Mine did eventually show up on my pituitary, but only after I'd had half my thyroid taken, and there was nothing else on anywhere else. But just wondering whether the size of your tumor on your pit gland was, it can make that kind of a difference.
That's another excellent question. Yes, you're absolutely right. This is part of a problem and the challenge is that people always assume that if the hormone levels are going to be high, the tumor is going to be large and it's going to be easy to detect. Unfortunately, as you've quite rightly pointed out, you can have a situation where the tumor is so small that they cannot pick it up on CT or MRI, and the hormone levels are still elevated. Now, in those situations, this is why I suggested that if you've done your homework and you still can't find the tumor, you may still have to treat the patient and continue to image until the tumor has matured, if you will, to a point where it is detectable on any type of scan. Now, having said that, there's a limit to the resolution also. The scans are not perfect. A CT will pick up a centimeter. An MRI will pick up about a centimeter. A PET scan will pick up about 7 millimeters. So size does matter in this instance. And obviously comparing scans over time, as again, like you've alluded to, can be very helpful, because if you can watch something grow, then you have more confidence that that is likely the area of concern. Now, the important thing I want to emphasize, though, is it doesn't mean that if you're going to watch it grow, that you're doing nothing. You are still using medications. You're still controlling the disease, because all of the other manifestations of a disease we talked about, heart disease, high blood pressure, all these things, they need to be addressed. So you can treat the growth hormone IGF-1 excess while you're still continuing on a periodic basis to look for the source of the disease.
Anybody else? Okay, another one. Okay, here we go.
Has there ever been a situation where a person has a typical tumor in addition to one of these other tumors that you talk about?
That's a very good question. I would say, so I can tell you, I've been around for a long time, and in the instances where you see it at both sites, which is what you're alluding to, is exceedingly rare. I've seen it only in a couple of cases. 9 times out of 10, it just was, as the person before you mentioned, it was just too small to be able to detect it. I will also tell you that in most instances, while the ectopic is important, most of the time it is in the pituitary gland. Now, one way of making that distinction, and perhaps I did not make that point very clear, but do you remember the hormone that I mentioned called GHRH? Not growth hormone, but growth hormone releasing hormone, GHRH. That is a blood test. And that is a blood test which, when elevated, tells you with high confidence that the tumor is outside of the pituitary gland. And that gives you more justification for continuing to search on a periodic basis to look for the disease outside of the pituitary. And that will tell you that this is likely an ectopic source. Obviously, you have to prove it, but at least it gives you the impetus to continue to look for it. I have to emphasize, GHRH is not widely available. And it's one of those things that, unfortunately, you have to complain and be persistent, but it will be done. And it is available usually in major labs. Typically, it's sent to the United States where it is performed. But it's a very, very good test in the right setting to be able to tell you there is an ectopic source and it is making growth hormone releasing hormone.
Thank you. One more question, please. Wait.
further to that, you say you have to go in, you've got to pester until you get that test. Is it because the test is so expensive? Why are they reluctant to do it?
I'm sorry, which test were you referring to, blood or scan?
What would be the initial? Blood, and then they would scan?
Okay, so let me start with the scan part. Because of the fact that now the PET scans and this PET scan has been approved for neuroendocrine tumors, you will not be charged for it as a patient. So that's a very, very important thing, because we used to have to send people overseas to get them done, and it was quite a lot of money, obviously. So the scan, there's no cost to the patient. The blood, and specifically GHRH, it depends on your institution. If it's done in a major hospital, the hospital will have to accept the cost. If it's done in an outside lab, then you may be charged a fee for it. I cannot quote you exactly, but I would argue that even if they charge you, let's say for argument's sake, $100, it's probably worth it, because the amount of hassle and inefficiency that will come from not knowing and doing things unnecessarily will probably end up costing you a lot more in many different ways, including financial.
Thank you so much, Dr. Ezzat. This has been an excellent presentation, an excellent talk, and I really wanted to bring out this topic because of just what I know I've done in the past, but just knowing that that it exists, that it's there, and it affects us like acromegaly. So I think we're done with the questions. Oh, one more? Okay, hang on.
Hi, Shereen, it's Michael Cusimano.
Hi, Michael.
Sorry that you weren't able to make it. Thank you for that excellent talk. There's a couple of things that I know you've said, but to just emphasize, can you tell us about the proportion of patients coming into your clinic, or maybe your clinic is a little different than most endocrinologists, but into the general endocrinology clinic with acromegaly that have a pituitary source versus a ectopic source? That's one. And the other is that I see it routinely, and I'm sure the endocrinologists see it, is that not every MRI is made equally. Most family doctors, they suspect acromegaly. If they do, they're really good, but they ask for an MRI of the brain. And what patients need is an MRI of the pituitary. It's extremely different. And so we see over and over again that they have an MRI of the brain. It's like looking at this whole room. No, I want to look at this one pen here. And they do the MRI very, very differently. So the systems are nice that we can get the PET. I can tell you that the last 10 patients I tried to get a PET, I was refused. So they're not that easy to get. But getting a proper MRI should be within everybody's realm. So before we jump to everyone getting a PET, because they're limited, tell us a little bit about that proportion and the type of MRI they should be getting.
Thank you for those comments, Michael. I'm in full agreement. And as you saw, I had in one of my slides where I said, obviously, the importance of the experience of a neurosurgeon. And if you recall, my second point was that the quality of the MRI was equally as important because, as I'm sure you will agree with me, that's the roadmap that the neurosurgeon needs. So you're absolutely right. In a setting of the diagnosed or even in recurrent cases, as you well know, identifying residual or recurrent disease is even more challenging than diagnosing it in the first place. And you're absolutely right. The MRI is dependent very much on the technique, and not only on how it's being requested, but how it's being protocoled by the radiologist, how it's performed, when images are acquired after the contrast is administered, and at the end, how it is interpreted and how it's reviewed by the radiologist and a neurosurgeon and hopefully the endocrinologist. So you're absolutely right. There are many steps in between. In answer to your question, if I were to take, 10 patients with acromegaly, and if I were to focus on those in whom I get the referral from an endocrinologist saying the patient has acromegaly, elevated growth hormone, IGF-1, we can't find the tumor, I will say that in about 8 times out of 10, we repeat the MR and we do contrast enhancement, and sometimes we do the dynamic ones. As you know, the disease will be somewhere in the cavernous sinus, either in the medial or sometimes within the cavernous sinus itself. And I know that for a fact because we can validate it afterwards after our intervention. So I cannot overemphasize your point that a very good high quality MRI is important, and sometimes it needs to be repeated over time to see if there's any progression. And so that's 8 out of 10. In 1 out of those 10, it will be ectopic, and I will find it. I should point out, if you're going to get the PET scan approved, depending on how well the application is prepared, and you're absolutely right. It is reviewed by a committee at a CCO, and if it's well justified, you will get it done. If it's not, or something is missing, you will not. You're absolutely right about that as well. In 1 out of 10, I will tell you, I fail to find the source, and I will treat those patients, but I have to sit on firm grounds that they do have elevated growth hormone IGF-1 and that it's clinically meaningful, and lowering it is clinically meaningful. I'm able to monitor it, and I continue over time to look for its source. So I will tell you, in 1 out of 10, I will fail to find that source, but it doesn't mean that we don't try.
Okay, thank you. So I would just like to thank you very much for coming on and presenting for us and asking all these questions.
Thank you so much. Thanks.
Okay.